Hola, buen día. Soy el Dr. Samuel Bukrinsky, CEO y Director General de Miss Implants México. Es un honor para mí contar con su presencia en el cuarto Simposio Nacional e Internacional de Miss Implants México. En estos tiempos difíciles a los que nos estamos enfrentando por la pandemia y los eventos presenciales no son posibles, por esta ocasión realizamos nuestro evento de manera virtual, ampliando nuestra plataforma educativa, adaptándonos a las necesidades actuales para dar origen a nuevas formas de transmitir el conocimiento, como lo es este gran evento científico que ha generado gran interés, no solo a nivel nacional, sino también a nivel internacional, con presencia en Estados Unidos, Canadá, Latinoamérica, Europa e Israel, entre otros. Aprovecho la oportunidad para agradecer a todo el equipo de Miss México, así como a Miss Israel, por el apoyo brindado para llevar a cabo este gran evento. Quiero darle a todos la bienvenida a nuestro simposio, el cual declaro oficialmente inaugurado. Muchas gracias.
Hello, I'm Dr. Galip Gürel from Istanbul, and I brought my warm greetings from Istanbul to Mexico to start with, being the organizer of this webinar, which will be broadcasted worldwide. So with that, look at the photo on the right. These are our freedom days before COVID. And unfortunately, this is now how we are dealing with all these swimming masks completely covered, loops outside. Still, please, anything besides the lecture, more important than that, protect yourselves. That's the only way to fight with COVID. Now, coming to the topic of my lecture, which is setting the stage before you start, I think in every dental procedure, like most of the things you do in life, you have to have a workflow with a full understanding of what your aim is, what your target is, what your workflow, your path will be in that whole workflow, so that you will know what to do in the beginning. You will decide on your treatment planning and finalize it accordingly. Simple enough. When you see cases like this, I think this is impossible to come along without a team, without being interdisciplinary, and without seeing the final result from the beginning. Even if you cannot physically see it exactly the way it will finish in the beginning, you should stage your treatment. So at the end of first treatment, I will reach this part, say maybe end of ortho. The second one, perio, I'll go there. And then finally, prosthetically, I will end up the case the way I want. And of course, all these cases need an aesthetic design. Well, in our workflow, in our daily practice, this is the basic steps that we cover. But when you look at it, the first column on the left, data collection, communication, it's sort of a technical issue. It's like more of maybe even your staff can do it. The other side is full of knowledge, getting the treatment planning and deciding on the treatment. However, all these things on the right hand of the screen will based on your design. And when it comes to design, it's the most creative part of your whole treatment. That is the part that probably will differentiate you from the other colleagues. But when it comes to design, it should be visual, meaning that I should be able to share it with the patient immediately and that should be my guideline for the rest of the treatment planning and the treatment itself. So I don't care in cases like this, you go digital, you go analog, we have to have a starting point and then its execution. Well, that starting point, even the mock-up can as well be digital, even though with my years of experience, I prefer to go freehand carving direct mock-ups, which I create a connection between the patient and myself immediately, and then decide on the tone of the treatment for the future. So for that, if we go back to basic fundamentals, regardless of being digital or analog, and talk about the aesthetic design, the heart of it sits on the mock-up. The idea I came up maybe 30 years back, and then which evolved itself gradually, trying to see at least the outlines of my final design before I start. So now the three steps that I always use in my treatments in a case like this, where the patient needs an aesthetic change of the color, the size, the shape of the teeth, simple enough, I have three steps. The first step is always the mock-up. So take a composite freehand carving, place it in the patient's mouth, trim it, shape it, light cure it, and one thing you have to take into consideration and pay attention is that your starting point after you finish two centrals should be the position of the incisal edge of the centrals. And then you will be building the rest. This will influence many, many things in the rest of your treatment and treatment planning. And as you can see here, if you end up with a mock-up like this in 10-15 minutes, depending on your skill levels, even if it's 20-30 minutes, it's worth it because the patient sees your effort, the patient sees the outcome that she will get if she accepts the treatment with this mock-up. However, don't forget that this is your first visual communication, meaning that if things go wrong here in terms of the aesthetic design, the patient may end up with some question marks. So, I mean, if you want to invest time, in my opinion, invest in doing this mock-up, which will tremendously have a positive effect on case acceptance from the patient's view and will guide you in a very proper way for the rest of the treatment. So even if you do a wax up, a mock-up properly, or if you're not happy with your mock-ups, just set the centrals, set the incisal edge position, photos, if you're going digital, intraoral scanning, send it to the lab. And the second stage is getting a very nice wax up and its application into the patient's mouth before you do anything. No injections, nothing. The patient has lips that are not numb. She has the control of everything. And I named it years ago the APT, the aesthetic pre-evaluative temporaries. You can name it as transfer of wax up into the mouth, but this is stage 2 to see my final outcome in the patient's mouth before I further go ahead. If it's veneers, okay, I may start prepping here, but if it's for another reason like planning a case for an implant, okay, this will again set my tone. We'll sit with the team, talk about grafting, implant positioning, all these details that an implant surgery needs. But fundamentally, first I have the mock-up. Second, I have this APT in the patient's mouth. May need some minor adjustments or not. And once we get the approval of this patient, I'll prep the teeth through that with a very solid reference through my APT, my final facial aesthetic contour, and always end up with the most minimal prep designs So happy to see these photos in almost every article or lecture when people prep the teeth, prepping through the APT, and really getting the best out of it being minimally invasive. And then with the impression, you can use any technique you like. Here we are using the pressable ceramics with incisal layering, and simple enough, this is the smile we create in that patient just by following the three main steps that you need to do, starting with a mock-up, followed by a nice wax up, and if the case is a complex case, going backwards, doing the reverse engineering, meaning that how can I reach to this excellence in aesthetic outcome if I will go with ortho, if I will go with implants, see the possibilities. If things are impossible, share it with the patient, but mostly it will be very nice, fluent workflow that you will discuss with the patient. It's not going to be only the treatment itself, but it will have a huge impact on treatment plan. So with all that said, let's move to our patient that I would like to share with you today as our case. So coming back to the patient that we will be talking about today, it's the same. It's the same in the sense of once we see the problems, once we see the smile, first we have to understand the aesthetic defects, the biological defects, what is missing, and the treatment plan according to the final design that we will propose to the patient. So let's see what we have in this case in the patient's mouth. Simply, restoration-wise, there's a Maryland bridge between the right upper central and canine. There is this pontic, which is sitting on the soft tissue. On the other side, there's a deciduous lateral, left upper side, and that is displacing naturally a short root in this location. So besides the arrangement of this setup, the teeth, we can see that we have lots of gingival asymmetries, and together with the asymmetries in the incisal silhouette. So, like in every case, we will start with the smile design. And the first things first for a smile design is a mock-up. Whether it be a direct mock-up in the patient's mouth, or whether it be indirect, like a wax-up, which will be transferred into the patient's mouth, or a digital design that can be transferred again back into the patient's mouth. So now, working on the incisal silhouette, the beauty of working with the mock-up in the patient's mouth is that we can work it in two ways. One is upgrading the incisal silhouette, and that starts with the position of the incisal edges in every single case. So once we set this, we start setting the tone of the smile design, and then accordingly, which will go up apically and talk about the proportions, that will decide the ideal layout of the gingival silhouette. So setting the incisal silhouette, incisal edge position, the arch of the incisal silhouette, which can be triangular, which can be ovate, which can be flat. And all these three designs will affect your final smile design that will affect your gingival architecture, that will affect, if we are going to work with implants, exactly your implant positioning. So having this setup, the incisal silhouette and the gingival silhouette, I will start doing my first direct mock-up in the patient's mouth, and this is what will come out in a few minutes. So this is the fit of the smile with the patient face, and I don't even need to say that, but every smile design should be facially driven. If we don't see the face, plus if we don't feel the personality of the patient, the design will be unsuccessful. When I say personality, like if the patient is a dynamic patient, so we should concentrate on inclined lines, which represents dynamism in the visual language. And instead, if we just use rounded shapes, I mean, even though when I make a close-up photo, it will look okay, but at the end, the patient will not feel a connection between that design and what you did. Or vice versa. If the patient is a calm person, and if we apply aggressive lines, the result will be the same. It will be a failure. So having all these things in mind, today the purpose of this lecture is not to talk into details of the smile design, but these are some highlights I would like to share with you, because I feel it very important when I do my direct mock-ups in my daily practice here in Istanbul. So once we have this design in the patient's mouth, now we can talk about a prosthetically driven treatment planning. So this is important because that will start the steps, and every step will have a reason to bring it towards what I designed in the very beginning. So our decision for this case is starting with orthodontics. And orthodontics, just because of the angulation of these two teeth, the roots are like in a very close proximity. And then we will hope to place an implant into that empty space, and also another implant into this deciduous tooth, because the patient is looking for the aesthetics. The patient is not dying to have an implant, to have ortho. She just wants to look better. But okay, I could have used or placed a veneer on the left upper lateral, but then this very short root will not support it. I could have planned to place an implant into this zone, but because of the roots inclination, it will not happen. The patient doesn't want ortho, doesn't want braces, so finally we get her into using aligners, and with align therapy, orthodontics, we will try to change the position of the roots and get the soft tissues aligned as much as possible. And you see the classical stoppers for these aligners on these photos. And at this stage, after 9 months, the patient says, I'm fed up with this. I don't want to continue with ortho anymore. So it's a tough call. The thing we have to do, or we decided to do, is okay, let's do another mock-up and see how it looks, and then we will discuss with you whether to continue ortho treatment or not. And just like in here, I make my second mock-up, and as you can see here, we're still keeping these stoppers for the align therapy, but I am placing my mock-up by pushing it on the tooth surface so that the patient will get the ideal contour, not taking these bulky areas as a reference, but taking the lips and the lip contour as a reference to set this smile design. So once we do this, the patient says, I like it, let's go with that. Well, we had some doubts about the zone apical to the lateral on the right-hand side, because the roots were too close. Our orthodontist was asking more time to make it more upright. But the patient says, no, I'm done with it. I don't want any ortho anymore. And this is real life. These things happen. So we continue with our setup. Well, how did I come to this smile design? First of all, I have to take the lips into account when it comes to incisal edge positioning of the teeth. In this case, when the lips are at rest, as you see in here, it displays some tooth exposure, which is great, which gives a very youthful, dynamic appearance. And then we would like to see the full face, the fit of this on the full face photo. And these are some photos that I use all the time just to make sure that the design is not only looking okay in 2D, but also it's well oriented in 3D. So one of them is the 12 o'clock position, which is taken when the head is bent down, and this gives me the beautiful silhouette of the arch position. This is extremely important. You have to take it seriously, because if the arch is like this or like that, at the end of the day, the final result will not be that successful. And another photo we always make is the full face retracted photos. The patient holds on the retractors, tries to keep the head like parallel to your camera. And this way we will be able to orient the eyes parallel to the horizon and the aesthetic plane of occlusion parallel to that line. This way you will truly eliminate a lot of canting if in some patients that needs to be corrected. And even in cases where you would need to open the bite, this is a great guide for you, because this way first you'll set the aesthetic setup and then adjust the occlusal contacts accordingly. If there used to be a canting, maybe in some parts you'll add more to those parts who need it to balance this aesthetic plane of occlusion. And on the other side, maybe you will subtract a part of the tooth during your treatment. So once the decision is made on finishing orthodontics, this is where we end up. This is the final day of orthodontics. The stoppers of the aligners were cleared out. So now here we have the patient. And how shall we continue with this? As you can see here, we have the teeth are reasonably well aligned. There is still some depression here. And time for me to do my wax up. So this was the final mock-up I made before we took the parts for the aligners, and I am transferring this impression into the lab so that they will finalize the wax up according to my detailed wishes. So that means that the shape of the teeth, the interproximal areas, the gingival embrasures, incisal embrasures, and once this is done, I will get this model and I'll prepare a way to transfer this into the mouth. Well, this can be a simple alginate impression, which I don't really advise. It can be a normal silicone impression from a normal tray, or like you see here, you can make some customized trays, fill it up again with silicone, and then make the impression of this wax up. Why is it important? Because if we can create a narrow, balanced silicone between the tooth and the customized impression tray, the fit of this tray will be very rigid, and you will be able to transfer all the details into the patient's mouth. Just like in here, once we transfer this final wax up into the patient's mouth, I think it looks very natural, very nice. Now, besides ortho, we haven't done anything yet. The decision, as you see, is that we are planning to place hopefully 2 implants on the sides of the laterals and veneering the rest of the teeth. Let's see if we will be successful in that approach or not. Now, what are the steps we go through when we think about placing an implant into the patient's mouth? Regardless of anything, number 1 is this wax up transferred in the patient's mouth. I named it like the APT, aesthetic pre-value of temporaries. You can talk about it like the final mock-up, I don't care, but this has to be placed in the patient's mouth in a very precise manner. Why? Let me walk you through. Look at this red dot in here. This corresponds to the zenith of the wax up. The wax up is not done just like a wax up, but if you're working with a lab who has a beautiful understanding of what is going on in an implant therapy, who is taking care of the soft tissue depressions into account while doing a wax up, just like Hilal is doing in this case, that point, that zenith point means a lot. Why? This will help me position the implant in the best way in 3D. How? Let me get this point over the close-up photo of this wax up. And as you can see, the wax up is not just emerging from the soft tissue, but it's coming out with an angle. And then you see the facial appearance of it. The only reason to that is the small soft tissue depression in this area. And when the lab takes this into account, my job is a lot easier, even though at this moment it looks a bit weird as if it's coming out, but it's coming out with a beautiful angle from the zenith point all the way down. But this point not only represents me where my zenith point is located vertically, this also shows me where I am positioned mesiodistally, and even more importantly, where I am positioned buccopalatally. So in a sense, this zenith point is really guiding me in 6 different directions. So once I have this, then I have to work on how to place my implant. Well, you could have done it like the old school way without caring all these things, just open the flap or flapless, place the implant. But I must admit that probably since the last 5-6 years, we do almost every case with an M-guide. It's guided surgery. Why? Because I can easily set my stage, as I mentioned before, due to my wax up, due to the form of the tooth that I want to finalize my implant reconstruction. Taking that into account, I'll go into the software, which I will be able to position my implant. in the right place in 3D. And then I will continue with the M guide guiding me to place the implant in the patient's mouth. So in order to get an M guide, which should be prosthetically driven, I need 3 files, like all of you would need. Well, one of them is the original STL file of the patient, meaning that the existing teeth that you see in the patient's mouth. The other one will be the STL file of the wax-up, and that wax-up carries lots of detailed information in terms of the final outcome, and a CT scan of the patient, which we will be able to merge all of these together at the MIS Guide Center with our dearest Luis, who has always been helping us tremendously, and really I appreciate his efforts on working with people all over the world, trying to match these wax up original teeth and the STL file, and according to this combination, trying to position the implant in the best place it could ever be. So we start planning the case, starting with tooth 22, the left upper lateral. The goal here is, if possible, if we will be able to physically place the implant, possibly getting a screw retained restoration on top, which will have tons of benefits when we compare it to a cement retained restoration. Okay, now you can clearly see that this blue color is our design. The sort of brown color is the original position of the teeth. And when we overlap it, see how clearly we can see the axial position, and here the screw is coming out from the palate, which is extremely important for screw retained restorations. And then from here we can see the design of the lateral and implant positioned exactly to where we want the axis of the tooth. So we position that on 22, but I will go into more details on 12 because we are in a very restricted area here. So we have the CBCT, we have the wax up, and we have the original space that we have in the patient's mouth. And when you look at the right bottom photo, I think this is a great side of the MIS Guide planning software. As you can see here, when I zoom this photo out, there is this orange line on the side of the implant. So what this means is that it's like rounded. What that means is that even though I may have a physical space that I can place my implant in between two teeth, biologically I would need this extra step for securing my implant positioning, leaving 1.5 millimeters from both sides of the adjacent tooth. So that origin or orange line going on both sides, unfortunately in this part says stop. Be careful, if you place it, you will get into trouble with the adjacent teeth. So even though our wish in the beginning was to place 2 implants on 2 laterals, number 22 is a done deal. But because of this proximity of this implant to the roots, which we couldn't upright fully due to the patient's demands on giving up orthodontics, Uh, Number 12, unfortunately, will not get an implant. So with this, deciding that we'll have implant on 22, we receive our prosthetically driven M guide. And the beauty of that is that when you get an M guide, it's not only the guide you'll be using for surgery, but you get this stereolytic model of the original teeth and arch. So in many cases, it helps us big time using this main impression stereolytic model on designing our provisionals or anything you want to do on that to visualize what the final outcome will be. It's as if you hold the mouth in your head and you have the M guide on top of that. Now, time for surgery. Okay, so we set the stage with the aesthetic outcome. We went through some stages. We went through ortho. We went through our last mock-up. Lab did the final wax-up. We merged these things together. We got the guide, and now it's time for surgery. So what do we do in surgery? What are the steps we have to take or think about before jumping into the surgery? So there are three things we have to be focusing on. One is, of course, the implant placement that we already decided. The other one is the connective tissue graft that we may need to load, and in this case, for sure, because of the depressions, and the type or nature of provisionals which we have to apply in order to start architecturing the gingival sites. So starting with the connective tissue graft, it's the soft tissue preparation for the whole procedure. You can see that we've done this case with my dearest Marcelo and Gustavo. And to begin with, before even we place the implants, they set the soft tissues, the connective tissue grafts, before we do anything. But how do we get this? How do we decide on that? Well, as you can see on the right-hand side of the patient, left to the screen, we have a vertical graft, which will mimic the root contour. Just because we're not placing an implant there doesn't mean that we should leave the soft tissue like this. Even though we will have a pontic in that area, we need to create some convexity as if this pontic has a natural root. And on the other side, we will be supporting the neck of the implant, which will be a transition from the deep zone to the superficial zone. This is why we get these CT, the connective tissue grafts. Well, I don't do surgery, but just to give you a brief idea on how they work, is that simply this is the layers of your soft tissue. At the very outside, which looks in the inside of the mouth, we do have the epithelium. So what does this mean when we plan to take a graft? Well, simply this part, this epithelium, has to be the epithelium, the epithelias. So we will not be using this when we bring the connective tissue graft into the mouth again. The other layer, which is close to your bone, to the maxilla, is the submucosal area. Well, what is different for this area? That, I mean, you end up in submucosa if you take a thick graft. That means your graft, part of this part of your graft will be glandular, rich with fatty tissue, which makes it very unstable. So this is why that part is also not the best part to make the graft. And if you go that deep, I can guarantee you that after surgery, the patient will suffer a lot if we have taken like a full thickness graft in that area. Well, the most secure, the most valuable zone is that zone between the submucosal layer and epithelium, which is the tissue rich of fibrous collagen. And if we can take this is the creme de la creme of this graft that we should be using in the patient's mouth. Well, another thing I learned from this great specialist is that once you take this graft, there is this side which is facing the retipex of the area that was looking for towards the inside of the mouth, and the other side, the deep side that you take. And they claim that if you use this deeper side, if you reverse this mock-up, this graft, and use the deeper side outside in the mouth, it will have a great color reflection through the existing tissue of that patient. So there are ways to de-epithelize the tissue. The way I love when Gustavo and Marcelo are working is that they de-epithelize the tissue in the mouth before they took the graft. To me, it's very logical, especially from a prosthodontist who is working with the burrs all day long. If I were to be doing surgery, probably that would be the way I would prefer to de-epithelize the tissue. Until how deep? Probably until the tissue starts bleeding. So once they de-epithelize this tissue, they take this connective tissue graft, the size that they would want, and you see once they take it, the fatty tissue here, but still they were away from this deepest zone. And what they plan to do, or they are doing now, is that once they take this connective tissue graft, they place a special suture there in which, after they finish suturing, they will insert a collagen sponge, which will be a barrier between the wound side and inside of the mouth. And see how simply you can slide this into the patient's mouth and end up with this protection layer. So also, if you want, you can use something like an FX retainer, which will compress that tissue if you have taken massive grafts from this patient's mouth. But for this one, that kind of protection is more than enough. Another way to de-epithelize the graft is also manually in your hand. If you have these skillful hands, you can easily de-epithelize it outside. So now we have the grafts ready. We go into surgery and, of course, implant placement. The decision is that we'll be using the M-Guide. We'll be using the V3 implant, 13 millimeters, 3.3. And on top, we'll be using the Connect abutment, which I will explain in a second. So in this case, you see how beautifully the M-Guide is positioned on the teeth. And I think, I haven't used any other guide, but I can tell you that the fit of this guide is unbelievable. We never spend any extra effort, try to seat it. This part is not going in. No, when it comes, click, it's on place. and it holds stable. In cases when you're placing multiple implants, maybe you would need a support to hold it in place, but in cases like with 2, 3, 4, 5 implants, it sits like perfect. So this is how the surgery starts. Gustavo and Marcelo, they extract the tooth, and then through the guide, they use the pilot drill and the drills necessary for the size of the implant that we selected. And simple enough, they are positioning the implant into the socket. Well, one of the mistakes done at that stage is that, especially for the experienced dentists, they go into drilling through the guide, but after that, placing the implant, they do freehand. But I would highly recommend placing the implant through the guide. Then you go exactly to the spot that you pinpointed during your planning. And then just releasing the soft tissue, placing your soft tissue graft inside, and simple enough, the implant is in the place, the soft tissue graft is in the place, and now, as you can see from the occlusal view, here comes the importance of the correct implant placement and combination, of course, with guided surgery, because when we overlap the CBCT over the existing tissue, over the final wax up, the crown design, this is where we end up. It's like shooting from 12 on a target. So what does this tell us? Well, first of all, it's very basic rules, but sometimes it's not taken into consideration, and we end up with some problems. Number one is we have to have 1.5 millimeters distance from the adjacent teeth. So that was the reason why we couldn't place the implant on the other side. So besides this mesiodistal placement, positioning, also buccopalatally, we have to have a space 3 millimeters buccal to the implant positions that we plan. Why? Because that's the area where we'll be grafting, where the blood clot will go, and where we'll have the nice contour and a soft tissue, which I will address in a few minutes. The thicker the soft tissue we build there, the more stable all the aesthetic outcome and the implant itself in the future. Well, what is the consequence here? As you will see, if we will have a thin tissue existing or left after the surgery, we will have more bone loss, and research tells about 1.17 millimeter average in a year. But on the other side, if we have a thick tissue, 2 millimeters, we'll have less bone loss, and in 1 year it will be like 0.21 millimeters. So this is a nice way of thinking how to deal with the soft tissues. And in many research, it proves itself that if we have a thick biotype, or if we thicken the biotype more than 2 millimeters, we will have very stable results. The other reason why we should have a thicker soft tissue on the implant side is the color issue. Well, one of the parameters that influence the implant aesthetics is the color of the peri-implant mucosa. If we see any darkness showing through due to the abutment's nature, the patient will not be happy. And mucosa thickness is a crucial factor in terms of discoloration caused by different restorative materials. But on the other side, if we do have a thick soft tissue more than 2 millimeters, no change in color will be able to be detected by human eyes, whether it is titanium, zirconia, or ceramic. So once you have the thick tissue, don't worry about the color of your or nature of your abutment that you will be using. So that brings us to connect, which I find extremely useful when I'm placing the implants, when I'm thinking about my prosthodontic solutions. And let me walk you through this briefly. Now, the important thing, starting from the treatment planning, is trying to decide where your final gingival margin will be. And you can only predict it with a direct mock-up, with a beautifully designed wax-up, which will be seated over that tissue. So this is what we ended up. Let's say this is our projected final gingival margin that we want to see after the whole treatment is done. And this is how we decide on positioning our implant vertically. As you can see here, we're measuring 4 millimeters from the expected final gingival margin and then positioning the implant. Now, from here on, we have some options about the restorative work. So what is this? Well, simple enough, I can place a titanium provisional cylinder to create my provisional, let's say, which is okay. I have no objections to that. However, the area between the gingival margin and implant should be filled, let's say, with, as an emergence profile for my provisional, with my hands. It is still okay. I can build it, and the key here is trying to build it as narrow as possible. However, the downside of this is that if you consider these black lines that I throw into this photo as the bone level, which we position the implant inside the bone, what will happen is that for some different reasons, when I start taking this provisional in and out, what will happen is that eventually I will have some bacterial infiltration into that area, and this bone in that zone will start receding towards the apical, which will not be nice for the, at least the aesthetic outcome of our implant. So what if we use the connect instead of using the traditional way of making a provisional and the final restoration? Is that once we place the connect in the patient's mouth, we should be able to torque it with 30 Newton. And once we do that, the connect and the implant becomes like one. And when this becomes like a one-piece implant, as you can see on the screen, two things happen. One, the first thing is we carry this implant from a bone level to a tissue level implant. And everything we will be dealing with from here on will be always above the bone level. And also, we are creating a biological seal between the implant itself and the connect. So, because of this cylindrical fit of the connect into the implant, we are technically sealing this zone, the implant neck, let's say, and we're carrying this all the way up to here. And because of some micro movements during function, if there will be some bacterial invasion, it will be stopped at this level without reaching the bone, without reaching the head of the implant. So this zone is being sealed with the use of connect and carried all the way coronal to this area. Well, about prosthodontics, Well, this has tons of advantages because again, I will prepare my provisional titanium cylinder on that. This is my expected future provisional and crown and porcelain crown, let's say. And the thing important here is I still have the subcritical zone that will be designed by my provisional. And on the other side, what I need to deal with, the deep zone, is very, very minor. Because from that 4 mm depth that I placed the implant, my 2 mm connect is covering up that space. I already have to have a 1 mm super crestal zone on the margin of my crown. So I'm only dealing with 1 mm of connection in that zone. So even if I do multiple trials in and out, I'll be all in soft tissue level and it will be very protective for the implant. Okay, so enough said for that. Let's switch into the provisional. Well, why do we need the provisional? At least for the soft tissue architecture. So what do we target here? Well, after GBR or CTG, we always have to place a provisional and start building the soft tissue architecture. But when we talk about provisionals, it comes to loading. And there's a nice article, chapter of Stavros, who brings a very simple solution to what can happen. Well, basically, if we can have a primer stability of the implant more than 30 newtons, we can go immediate loading. And when I say immediate loading, just like you see on that, we can place our provisional crown over the implant the same day. And care should be taken to the deep zone. First of all, the superficial zone that marks the margins of our crown, and behind that, the deep zone, which should always be very, very narrow. Now, what happens if the torque is between 15 to 30? Well, then we need to load the implant in a delayed manner. Well, when it's delayed, does it mean that we should just place a healing screw and suture and then try to work on the gingival architecture months later? Not really. What this means, when you still have primer stability more than 15 newtons, is that you will be dealing with a customized healing abutment, meaning that everything from the top of the connect, let's say, until the gingival level will exactly mimic what we will expect from the final restoration, from narrow to large, but we will stop it at the tissue level, and you will see it like this on the X-ray. And finally, what will happen is that we will cover it up with a, let's say, Maryland bridge. So what if the primary stabilization is less than 15? Well, then you should use a cover screw, healing abutment, and just bury the implant. Well, having said that, we should not use provisional removables, which will be in contact with the surgical site. But with my experience, with the design of V3, which is very sharp, which engages itself into the bone, it's very, very seldom. I've never witnessed having a torque, a primer stability less than 15 newtons. So with that design, the primer stabilization will allow you either making a customized healing abutment or provisional itself. So provisional for the soft tissue architecture. Okay. Now, how do we deal with this? First of all, when we're designing a provisional, we should think about immediate or delayed. So this is the design that we create. It's like a Maryland bridge, but the inside of the crown is empty. So if it will be a delayed loading, we will be working from the top of the implant to the soft tissue as a abutment architecture, narrow to wide, stop it at the gingival level, and then use this bridge, fill the inside of this crown and use it like a Maryland bridge in this case. However, if we can immediately load the implant, we will still use this design, which has lots of benefits, meaning that, first of all, once the surgery is done and the surgeon tells me that we can load it, we will just empty that space, which is palatal to our design. And then once we place the tie-based temporary cylinder, from the area where we empty it, as you can see here, we will position the provisional, and the wings will give the stability to position it exactly to where it should be. And then we will drop some composite, light cure it, capture, and simply you will get a design like this. So the areas to be worked here, or the signs that this is giving us, is first the design of that Maryland crown, let's say. The margin is representing exactly the critical zone. The space between the top of the connect to that will let us build the deep zone, which the lab will focus on that immediately. And the area from there to the outside will tell us about the connective tissue graft that we need to place into that zone. So with all this package, when we come to that stage, you can see that the provisional is nicely placed. The soft tissue looks beautiful. This is after 14 days of positioning of the implant. You see the wound that the soft tissue graft is taken is healing perfectly, and 14 days and 3 months. See how nice the area the graft healed here, how nice the margin is staying over the provisional, which is an exact copy of our final design. So time for pros now, and in that meaning that we will now go for the final wax up. So at this stage, we apply our APT, the final wax up, into the patient's mouth, looking at her lips at rest, followed by half smile, followed by the full smile that we need to see with the nice integration of the final design. And just like in every pros case, I'll go to tooth preparation. I'll prep through the design we made and simply come up with my final prep designs. And in this case, you can see the premolars on that side, right side of the patient, will get 2 veneers. Here, the patient was fed up with the failure of her previous Maryland bridges, so she didn't want us to make a Maryland bridge here, but instead a DV vital tooth here. She wanted to have a pontic connected to a crown on that tooth. Number 21, 9, will receive a veneer. This lateral will receive a crown or a veneer, and these two teeth will receive two veneers. So another option of how to do it is that maybe you can create your design, abutment design, like a tooth with the superficial zone and the deep zone, and then bring this into the patient's mouth, as you can see here, treat it like a tooth surface, and then you make all your preparations through that, so that the lab will also have a chance to get a deeper prep over that veneer, as you can see here. If I'm prepping those teeth 0.3, I can prep this tooth-like abutment 0.5 millimeters, and then you see our final prep design. This is another case, but I'm just showing it as an example. The beauty here is that because of this abutment here, it's zirconia, we need to match the color of that with the adjacent tooth. And as you see here, the surface of my prep abutment on this zone, in the lab, we will be covering this all the way from up to down with a ceramic material, and we will hit two birds with one stone. One is we will get the ideal color under a veneer, and the second one is that even though we have great researchers by Marcos Blatz, Avishai Sadan on bonding zirconia to anything, I feel more healthier if I fire my ceramic over the zirconia abutment, fire it, end up with a ceramic surface, and when I finish it like a veneer on top of that, then I'll be bonding ceramic to ceramic, which is like unbelievably strong. So with this, easily the lab can continue on placing the wax and firing the ceramics. So in this case, what happens is that, as I told you before, we are prepping this tooth as a crown. We will get the pontic, veneer, 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 and here we will get the abutment and a crown on top of that. So we make our color transfer, but one thing extremely important here, you should not miss that detail, is that see how beautiful we created this critical zone. So in this case, I will make a digital impression, but I don't care, digital, analog. The minute I will take out this abutment, provisional abutment, the tissue will start collapsing. And research tells us that it's like almost as minimal like 30 seconds to maximum 1 minute. After 1 minute, it's completely collapsed. So when I will do my digital impression, the minute I take the abutment, so that I will use my scan bodies for my digital impression, before I get into there with my scan body, I scan the gingival architecture of this subcritical zone. And then I place my scan body and simple enough make the impression of this area. Then I don't care. The lab, you go monolithic, you go layered, you go digital, but at the end, you will have this beautiful design from the lab. Since everything had been planned perfectly, there are no surprises in terms of the form of the teeth, the alignment of the teeth, incisal silhouette, gingival architecture. And when it comes to bonding, again, it's the standard bonding techniques we use with a rubber dam. And this was the case when we placed the implant. And this is the final with the X-ray you see. What we had in this case is that we had the implant, and then we had the connect abutment, and then zirconia abutment on top of that, and layered with feldspathic crown. So this way, this is the X-ray 15 months later. This is a recent X-ray, and see the bone is holding perfectly in spot. And this is the look of the patient and final smile. So what I would like to share with you is that once you make your smile design architecture, let's say in the very beginning, and then carry this into your treatment planning, do your treatment planning accordingly with reverse engineering. And in this case, for example, not everything worked out the way we wanted. On the lateral 12, we wanted to place an implant, but the flow of the whole treatment didn't allow us this. Because of some social reasoning, the patient didn't want to continue with ortho, so we had to stop it, and we changed it. But because the basis of the treatment was solid, we moved immediately into that solution. And with this, I can easily show you the difference. Very solid, very stable. I think this is a very acceptable smile by the patient. So with this, I really would like to thank you for that time you spent with me. I would like to thank the MIS family, especially the Mexico branch, and look forward to being with you in some other occasions. Bye-bye.